a warm welcome to Glasgow, Scotland, Marilou. So I think we first met when on social media you'd been quite vocal about the whole supervised injecting sites, and that was, I guess, how I ended up meeting you, and hence why you're here today. And you're going to be included in our conference tomorrow as the keynote speaker. So our conference tomorrow that we're holding is working together to prevent drug-related deaths, and hence why we're wearing these T-shirts today, #Stop the Deaths, which is our public awareness strand to the event as well. So I guess the conference is all about reminding people that we are preventing drug-related deaths on a daily basis, but we need to be doing so much more, and that we can prevent drug-related deaths, and we all need to work together in order to prevent them from happening in the future. So really great to have you here. It would be useful if you could just tell us a bit about the work that you do and all the areas that you're involved in.
Well, thanks for having me. My name is Marilou Gagnon. I'm an associate professor in nursing at the University of Victoria. I'm also the president of a newly created Harm Reduction Nurses Association. And previously I was the founder and also managing a coalition of nurses for supervised injection services in Canada.
Great. So you're speaking tomorrow at our event. What can we expect to hear in your talk tomorrow? What are you going to be presenting on?
Yeah, well, I'll be sharing mostly 3 lessons learned from Canada, in my opinion, and also reflections on where we're at. So for sure, I'll spend, I think, the majority of the time explaining why, in order to save people from overdose deaths, to prevent them, we need to implement drug consumption rooms. And that's the one thing that I think we're doing well in Canada. So I'm going to share quite a bit on that, and also different models that can be used to do that, from very simple to more complex drug consumption rooms. So I'm going to share our experience. I'm also going to emphasize the fact that we need to stop making harm reduction so exceptional, and to understand that harm reduction needs to be about a standard of care now, and this is where we're at in terms of our knowledge and practice. And so I think that's also important, and simplifying the process of implementing harm reduction services instead of making them so complicated and requiring so much in terms of bureaucracy and government, to make this about standard of care that should be accessible to everyone who's working with people who use drugs. And then I'm going to be sharing the fact that our harm reduction is really important, but it needs to go hand in hand with treatment. And what I mean by treatment is also methadone, Suboxone, but also heroin-assisted treatment, hydromorphone, and that needs to be looked at together. I know sometimes people put a great deal of emphasis on treatment that is abstinence-based, but I think we need to look at the broader picture and see all of these things working together. So I'll be speaking to those 3 points.
Okay, excellent. So you know that at the minute we have what's actually a public health emergency in Scotland at the minute, with the rates of our drug-related deaths. So last year we had 934 people lose their lives through accidental and preventable drug overdoses. And whilst it's not been declared as a public health emergency, there's certainly been strong demands that is looked at now, because the rates are continuing to rise and the amount of lives lost is just, becoming exponential. Can you just describe a bit about what happened in Canada and how the public health emergency there was declared and what the current situation is?
We've been calling for a public health emergency to be declared the national stage throughout the country, but that has never been done. British Columbia is the only province that has declared a public health emergency, and that has really allowed the province to implement a lot of rapid solutions on the ground. Including what we call overdose prevention sites that are very more simple drug consumption rooms that can be done easily in the communities by peers and harm reduction workers and volunteers on the ground. And so that's allowed rapid movement, rapid response, but even that is not enough. The situation we face right now is a poison drug supply. So basically the drugs that are on the market right now are literally poison. And even though we've done a great deal from a harm reduction standpoint, it's really hard to see an impact of that, because people have no choice but to turn to a market that is poison. So we need to really rapidly expand access to safer drugs, and this is where we're at. I think what we can see, though, in terms of Scotland and its current situation, I don't think fentanyl is as much of an issue here, but I think when we try to prevent overdose deaths, we always say 2 things at very core is to never use alone and to have naloxone. And I think unless you provide safer spaces for people not to use alone, you can distribute naloxone to every single person in Scotland, but you probably won't see the impact of that. And also it's important to make sure that people are not afraid to call 911 for help. And that's something that we've tried to tackle in Canada as well with the Good Samaritan Act. So it's a piece of legislation that was passed so that people that call 911 can't be prosecuted or accused of a crime if there's drugs on the site.
And have you noticed a big difference from that? Do people feel more comfortable about phoning?
Actually, that's the one thing is that I would push for really legislations like that to be implemented everywhere. But the reality is that the culture on the ground of law enforcement and how cops really approach any calls that are related to drug hasn't really changed all that much. But I would still emphasize the importance of at least having a law that protects people from being accused of a crime when they're actually calling for help.
Yeah. And you mentioned when we're going to be talking tomorrow about the importance of treatment. So do you have any waiting times for people to get onto opiate replacement therapy in Canada, or how does it work over there?
Long waiting times for detox, for treatment is a very common thing in Canada. That's where we're seeing a lot of emphasis on harm reduction, but if people don't have access to treatment when they're ready, that's also a problem. So we want to work on both. What we are seeing, especially in British Columbia, is the implementation of rapid access to treatment clinics. So people are ready to start the day of, they start that day. And
okay, so somebody could just walk into a service and they could be started on a methadone prescription that day.
Yeah. Okay. Yeah, and nurses have played also an important role in making that service accessible. We've also seen really creative roles being implemented, for example, in the emergency room, where addiction nurses can work in the emergency room and actually go assess patients that are coming in after an overdose and link them with treatment if they're ready to do so. But most of the time, I think where we're failing is when people are ready, they're just not accessing it.
Okay. And when people are accessing treatment services and they're on opiate replacement therapy, are there any conditions attached to them being part of that treatment program? Are people discharged regularly, or are people retained well in treatment when they need it? How does that operate?
Well, the challenges are that it's hard to find a provider, a physician that will treat you. So first of all, there's that initial challenge. To get the treatment when you're ready is another challenge. So these two things are already not easy. We're seeing, that the implementation of treatment approaches comes often with a lot of monitoring. So either having to go to the pharmacy every day, which is not, an easy thing to do, and also some drug testing of your urine, for example, that is also not necessarily something that creates the best relationship. So those are the things that come up often. I think we're lucky in a way because now we're starting to see the implementation of other options, for example, using heroin or using hydromorphone for people, but these are not widely accessible. They're very exclusive to people in the downtown east side in Vancouver, and there's one program in Ottawa right now, but that's not accessible. So if people are not really doing well on methadone or Suboxone, if you live in any other cities, you're not going to be able to access a provider that's going to be able to prescribe hydromorphone, for example. Yeah. And so there's still a lot of work, and I would say the number one thing also that's coming up quite a bit is the fact that treatment centers are not regulated in the country. That means that anybody can open a treatment center and advertise it and make money out of it, and it's not always evidence-based, and they can be pretty dangerous to people, and people don't know that. So often they're desperate, as it can be quicker to access, then you have to pay a lot of money, but they're not evidence-based, so that's a problem. Yeah.
And you mentioned as well about the introduction of overdose prevention sites. How did they come about, and how did they operate? Can you tell us a bit about your involvement in that and how you were able to get them opened? Obviously when it wasn't legal technically to do it.
Yeah, the first one opened in the fall of 2016. BC declared a public health emergency in April 2016. So by the fall, nothing really had changed all that much. People were dying. They're still dying in way too high numbers. So people on the ground just decided, some very fierce activists just decided to open what we call pop-up overdose prevention sites. So basically setting up a tent outdoors, very basic, with gloves and naloxone, and just peers and volunteers that were just there to save people's lives. And at the time, really, I was visiting one of those sites and visiting Insight, and the time that I spent in Insight in 1 8-hour shift, we saw 15 overdoses in 8 hours. So that's kind of giving you a sense of the state of emergency at the time. And so based on that experience, then people starting to get really interested in overdose prevention sites. And then by December, it was getting pretty cold, and the Minister of Health in British Columbia decided to issue an order saying that these overdose prevention sites would become part of the overdose response. They would not require an exemption of any sort. They could just open, just to really respond to the overdose crisis. And that was very well contained within the British Columbia context. And then during the summer of 2017 in Toronto, one popped up in the park. And then we in Ottawa opened one the month after that. And so we opened ours. It stayed open for 80 days because of the weather getting very cold and the lack of support. We were forced to close. In Toronto, they received a donation of a trailer so they could operate indoors, and they worked for 10 months, just volunteer-based, without an exemption, without any kind of legal documents supporting what they were doing. So they were considered what we would call them like unsanctioned, and not necessarily illegal, but I mean, that's really like kind of a point that often people get really hooked on. But at the end of the day, we were doing what's right, which is being on the ground, saving people's lives, making sure they have a place to go and not use alone.
Yeah, for sure. And did you face any opposition for those being opened?
A lot. From immediate neighbors, from local politicians, from the media. People got really stuck on the idea of not following the rules when, like, historically, like, no progress has been made because people were following rules. It's often because people challenge the rules that things progress in our society. And we felt we were doing something that was right because there is a crisis in Canada. 4,000 people died last year alone. This crisis is really not showing any signs of slowing down. And it just seemed like this is what we needed to do. And we also were able to demonstrate that in order to save people's lives, like, it's not very complicated. You just need to provide them a safer space and to have people there with naloxone. It really comes down to that.
Yeah. So at the moment, we're in a position in Scotland where our drug strategy is being refreshed, renewed, and our drug-related deaths are at an all-time high. What kind of things do you think should be in that drug strategy?
Well, I mean, for sure, I would say there's one thing if it's drug consumption rooms. There's no doubt about it. They work. I mean, we've known since the early 80s that they work, that they actually has been no deaths in any of the overdose, the drug consumption rooms in the world. There's more than 130 at the moment, 130 drug consumption rooms. So we know enough about them to know that they work, and especially for saving people's lives. But even people that are, really kind of doubting that and kind of not understanding fully the role of drug consumption rooms and being for treatment, let's say, and wanting to put so much money in treatment, it's actually been demonstrated that people who access drug consumption rooms, for example, if we take the Insight in Vancouver, they're 30 to 35% more likely to access treatment and to go into treatment than if they didn't access that drug consumption room. So there is like a link also with other things than just providing a safe space for people who use drugs. There's also accessing healthcare, accessing treatment, and all of that is beneficial overall.
And in an environment where it seems unlikely that we'll be able to just go ahead and do that without Westminster government supporting that initiative in Glasgow and in particular in Glasgow and in Scotland, what else can we do whilst we don't have drug consumption rooms, and we might not have them in the immediate future? What other things are essential for us? Just if you were to give a quick snapshot of these are the things that you should be doing just now, what should we be doing?
Well, I would say then if you're unable to provide a safer space where people can go, that means at least naloxone to every frontline provider, bars, libraries, that should be massively distributed. Education, around what an overdose looks like and how to recognize it. Also education around like using different substances and mixing them together. So that would be helpful because that increases the likelihood of overdosing as well. And then having a piece of maybe legislation or something around with the police, working closely with them to make sure that people never hesitate to call 911, or in your case, I'm not sure.
999.
999. So I think those 4 things are kind of easy targets and should be done, you know, as quickly as possible. But I do think that if there's going to be education piece, recognizing an overdose and how to use substances in a safer way and not to use alone as much as possible, and then never hesitate to call for help and having naloxone on hand, but really kind of also expanding the front line is also like anybody who's like working in a bar.
Yeah, like anyone who's likely to
Yeah,
witness.
exactly. Setting where maybe a homeless person would go and during the day, or like any, like, you know, really expanding our definition of what the frontline people are and making sure it's there. And also maybe one thing that's coming out of Canada that's really good, and I think there's some really good work being done in the States as well, is some safer washroom programs where also, for example, in bars where you have some protocols in place or to really make sure that no one dies in the bathroom alone.
Yeah, okay. Well, thank you very much. That's
Thanks.
really interesting. Really looking forward to hearing your talk tomorrow. So thank you very much for your time.
Thank you.